Hey, so good evening, everyone. Thank you all for joining us for this fourth chapter of Mastery of Surgery, wherein the program goes about with first covering the radiological anatomy of a particular system, followed by master videos. So today we will be covering gastric cancer. We will start our first talk with our radiologist consultant, Dr. Aparna Kattare from Tata Memorial Hospital, Mumbai. She has been kind enough to provide us some time and she will be explaining the imaging in gastric surgery with surgical importance. Madam, over to you. You can share your screen.
Yes, thank you so much for the opportunity. Let me share my screen now. Can you see my screen?
Yes, ma'am.
And am I audible?
Yes, clearly.
Okay. Yeah. Okay. Good evening, everyone. So, I'll be speaking on staging of gastric cancer. So that would cover the basics of imaging in gastric cancer. These are the headings under which I'll be covering my topic. We'll be discussing the anatomy, then the classifications that are imaging wise important when we describe a gastric cancer or identify it. The modalities which are the most effective, obviously CT being the prime modality, will be focusing mostly on that. And doing the imaging or considering the imaging in consensus with the TNM staging of imaging, and just a brief note at the end for differential diagnosis. So let's start with the relevant anatomy first. What we need to know here is this is the stomach, as we all know, and this is the cardia, fundus, this is the body of the stomach, greater curvature, lesser curvature, and the entropyloric region. So the most important structures anatomically which we try to focus on when we look at CT scans is the lesser omentum and greater omentum when it comes to the CA stomach. And that's because most of the disease, once it starts getting T3 and the nodal dissemination starts, it happens through these two layers. So the lesser omentum is made of two ligaments, the hepatoduodenal ligament and the hepatogastric ligament. So everything that radiates through the lesser curvature of the stomach is basically what we are looking at. Whereas the greater omentum, most of the times what we feel, it's like this huge curtain that falls from the greater curvature of the stomach up to the transverse colon this way, that it rolls again, it goes down and it rolls up again over the transverse colon. But apart from the this gastrocolic component of it, there are also the two components, namely the gastrophrenic component and the gastrosplenic component. So these components together form the greater omentum. So the classification, microscopic classification, would be the intestinal pattern or diffuse pattern of gastric cancer. But what we like practically to look at on the CT scan would be the Borman's classification, which is the macroscopic appearance of the gastric cancers. So the type 1 would be the polypoid or fungating appearance. The type 2 would be the polypoid and ulcerating. So one was polypoid, but it was fungating. So it was kind of the proliferating one. And the other one is the polypoid with an ulcerating component. The third would be the ulcerated type of cancer with infiltration. And the fourth would be a diffuse infiltrative pattern, also known as the linitis plastica. So let's see this pattern. So this is the type 1 pattern, where this is a polypoid mass here, something like a cauliflower, just a bit wider perhaps, and it is fungating. Basically, it is proliferating. Okay. But the moment you find this kind of a crater within, it's like an ulcerating mass. So there is this polypoidal component as well, and then there is this ulceration. The type 3 would be more of a predominantly ulcerated type. So you see these mountains, craters. These are the multiple ulcers in this gastric cancer. And the type 4 would be the diffuse infiltrative pattern or the linitis plastica, often confused with a lymphoma. So, coming to the modalities, the main intention would be to classify the gastric cancer according to the TNM stage. And the modalities for this staging would be the endoscopic ultrasound, which is most accurate for the T1 and T2 stages when the gastric cancer has not crossed the gastric mura. Whereas if you want to see the T3 and T4 stages, it's the CT that we rely on the most. The CT may or may not be able to differentiate between the T1, T2, but it's highly effective when it comes to the T3, T4 disease. While imaging, what really helps is if we give a negative oral contrast, such as mannitol. If that's not available, maybe water, but that's not as effective. And we take the arterial, venous, and delayed phases. The MRI, not per se for the gastric cancer, but could be considered for the indeterminate liver lesions, which will change the prognosis and indeed the management. And a PET CT would be useful for end staging. However, it has a limitation that in signet, ring, and poorly differentiated cancers, there may not be much uptake on the PET CT. Let's start with the T stage and how we go about it. Let's go to T1. So T1 is the tumor invading the lamina propria or the submucosa. So here it is the T1 polypoidal mass, and you can see this muscular layer here, this hypodense area or the gray area here that you see, it is intact. It is probably not invaded. So this is probably a T1 disease, at least macroscopically. But the moment you see that this the same layer here is infiltrated here, okay, you see an interruption in this gray layer, and now the muscle wall is completely involved. So that is the T2, where the muscularis propria and the subserosa are involved. Going to the next stage, the T3, where the tumor penetrates the serosa without invading the adjacent structure. So here we see this is the mura, and this component here is where the tumor has gone beyond the gastric mura. So this would be T3. And the T4 here, this is the stomach, and it has invaded the adjacent structures. Here it's invaded the spleen and it's invaded the left lobe of liver. So that is the T4 disease. Coming to the end staging, the end stage is an independent variable for survival, where the common size criteria that we consider are 8 or 8 to 10 in short axis diameter. The limitation here is that nearly 50% of metastatic nodes do not meet this criteria. They are in fact less than 5 but they do end up having microscopic metastasis on histopathology. So, the Japanese Research Society has suggested the compartmentalization of regional nodes, and here's how it goes. So, the compartment 1 is the perigastric nodes. The compartment 2 is the nodes along the celiac axis and its branches. The compartment 3 are the nodes along the hepatoduodenal ligament, which is the part of the lesser omentum, posterior to the head of the pancreas, and along the root of the small bowel mesentery. So basically, we are going a bit inferior and posterior. This would be posterior to the head of pancreas and inferior when we are now going below the level of the celiac axis. It's in fact the root of the small bowel mesentery or along the SMA. And the compartment 4 would be the retroperitoneal para-aortic nodes. So what's important is that this compartment 3 and compartment 4 are considered to be distant metastasis, and the treatment varies accordingly. So, while there could be multiple stations that the surgeons, while operating, deal or talk in terms of that. In terms of the CT appearances, and practically, if we as radiologists manage to give you which amongst these compartments are involved, then I guess the surgeons get a fair idea. So let's go to the perigastric node. So this is the a plaque-like lesion here along the lesser curvature, and this is the contiguous node here in the perigastric or the gastrohepatic region, if you may call, along the lesser omentum. Also, you see some kind of a fat stranding here. This fat here, normal fat is like this, black, and here it is dirty like this. So there is some fat stranding, and possibly there could be a disease dissemination here. So that's the perigastric nodes. We see another small perigastric node here in the gastrohepatic region. We go next to compartment 2, which are nodes along the celiac axis. So here's the celiac axis, and we start seeing the nodes here. The size criteria is important, but more than that, we rely on the morphology of the nodes as well. A node that is rounded with the loss of fatty hilum or has an irregular spiculated appearance, there could be perinodal fat standing, all that points towards the node being possibly positive. Here are more of those nodes here along the perigastric region. And now this is of course a large mass and the bigger nodes along the perigastric region, as you can see. This of course is a T4 disease invading the spleen. Next we go to compartment 3, which are along the hepatoduodenal ligament, posterior, so retropancreatic, and along the root of the small bowel mesentery. So this is the pancreas, the body of the pancreas. This could be the head region or a section just inferior to that. And this is a large retropancreatic node that we see in this case of a CA stomach. Here are some of the roots. This is the SMA, and you are seeing nodes along the root of the SMA. Incidentally, we are also seeing the compartment 1 nodes here, the gastrohepatic, and perhaps this is a suspicious left para-aortic node too. So, which gets us to the compartment 4, which are the para-aortic nodes. This is a cornal section. This is the aorta, and here we see the left para-aortic nodes here, beautifully seen. Here are the large para-aortic nodes, and this is the gastric mass, which is the primary. The Furcow's node, as we know, is the left supraclavicular node, and needless to say, any case of gastric cancer, this has to be covered in the chest CT, and we need to see if it's present. Then we go to the M stage. The distant nodes, that is the compartment 3 and 4 that we talked of, as well as the supraclavicular, are considered as M1 disease, as is the peritoneal disease along the omentum, the ovaries, so the Krukenberg tumor, the rectovesical pouch, and there could be ascites as well. So this is another common site of metastasis, and then followed by the distant organs, liver, lungs, and sometimes bones. Adenocarcinomas sometimes give sclerotic mets. Otherwise, most of the times you would think of as osteolytic mets, but sometimes there are sclerotic mets. So here we see this is very early omental disease here. You see again, this is the normal fat which looks clean black like this. And once it starts looking a bit dirty here, has some nodularity, that is the beginning of omental disease. So this is, you have to be very careful when interpreting a CA stomach case and look for this kind of a dirty omentum. It's important not to miss that. And then of course there could be just discrete enhancing nodules like this. This is the inferior portion of the stomach where you can see the mass, but this section is mainly to depict this proper omental nodule here. So many a times there is no controversy that there is in fact omental nodule and disease. We see here, these are the two adnexal masses here, and this is a Krukenberg's tumor. Also, perhaps here is a deposit, could be along the, in the mesentery or along the serosal surface of the bowel. Another example of a pelvic deposit here, possibly a Krukenberg's. And here we see that there is a large disease here. I mean, it's a T4 disease. Probably the pancreatic head is involved. There is, of course, nodal involvement here of the retroperitoneal rouge para-aortic nodes. And we see a liver met here, typical peripherally enhancing bullseye lesion, multiple liver mets here. There's ascites also. So this is an outright metastatic disease. Coming to the last part, now that we've seen the TNM staging, the differential diagnosis that one needs to keep in mind, obviously you will do a scopy and biopsy all of these gastric growths, but it's nice to think of differentials right when you are imaging as well as radiologist. So the first differential would be a lymphoma. A lymphoma is more of a diffuse disease. Like I said many a times, it mimics the Linitis plastica appearance. But the moment you see some kind of a diffuse disease like this and typical retroperitoneal large non-necrotic nodes, you could start thinking whether this would probably be a lymphoma rather than a gastric primary. The second most important differential is a gastrointestinal stromal tumor or GIST. The typical characteristic of that is that it is a very well defined tumor and it is predominantly exophytic. So it's not really a tumor in the lumen, or it may just protrude in the lumen, but it's predominantly exophytic. The other differentials could be right in the enhancing nodules right in the mura of the stomach, such as a metastasis in a known primary elsewhere, a leiomyoma, again an intramural centered lesion, schwannomas as well. There could be gastric NETs, which are really extremely enhancing, intensely enhancing. Lipomas would show a fat within, hemangiomas would be enhancing again within the mura, or glomus tumor. So I've not really given too many images of this, because this is mainly for gastric cancer. And as surgeons, I think what you need to concentrate on is the T stage on CT, and the nodal disease as well as the meds. So that's what we focused on. So the take home message is that the CT is the mainstay of staging in gastric cancers. T1, in T1 and T2 disease, endoscopic ultrasound is much better than the CT for staging. Whereas once you go to T3 and T4 stage, as well as for N and M staging, the CT becomes the mainstay of imaging. MRI could be done for um, for indeterminate liver lesions as a problem solving modality. Otherwise, MRI really has no a role. Recently, there has been a talk of MRI to look for peritoneal metastasis, not just in gastric, but in other cancers as well. Peritoneal mets, which are occult on CT, not really seen, but on MRI, a diffusion weighted sequence helps. But that's something that's a work in progress. I thank you for your attention, and I hope this was helpful for you.
Thank you so much, Dr. Aparna. This was a very informative presentation, and it was definitely helpful from the surgeon's perspective. Thank you so much for joining us this evening and
Thank you.
sparing your valuable time.
Thank you.
Uh, we will now, I request you to stop sharing your screen
Yeah,
so I
I'll
can
do
share
that.
mine.
I actually need to rush for another important meeting. So would
Absolutely.
if
No
I leave,
problem.
I'm really sorry to leave this early, but thank you so much for having me.
Thank you. Thank you, ma'am. So we'll move on to our next presenter. Next is a video presentation by Dr. Devendra Parekh, who is a consultant surgical oncologist in the GI and Thoracic Department of HCG Cancer Center, Ahmedabad. He will be presenting a video on D2 lymphadenectomy. I now request Devendra sir to please share his screen.
Good evening, everyone. Is it visible?
Yes, sir, it's visible and you're audible. I request the
Yeah.
attendees to kindly post their queries for the panelists in the Q&A section so we can simultaneously address your questions.
I thank IASO leadership for giving me this opportunity. Topic for my today's discussion will be D2 lymph node dissection and radical gastrectomy. As we can see, gastrectomies are template procedures, whether we do distal, total, or proximal. Topic for today's discussion will be total gastrectomy, and we'll cover the patient positioning and the steps. As we see the position, there are four important components: reverse Trendelenburg around 15 to 20 degree, left up position, so that we can have a very dry field throughout the procedure, leg split, so that surgeon as well as camera person can stand in between. And whenever we are doing robotic assisted surgery, bedside surgeon is also sitting in between the legs. So leg split is very important with low lithotomy and arms by the side. So this is the typical position we try and give. This is how our OR setup looks like when we are doing robotic assisted gastrectomy. As you can see, bedside surgeon between the legs, vision card on the right of the patient, and very similar position for laparoscopic assisted gastrectomy. As you can see here, these are the port placement and the OR setup. Again, screen on the right side, on the head side. Right hand surgeon usually try and stand in between the legs. I'm a left hand surgeon. I stand on the left side of the patient. 5 ports are used for laparoscopic assisted procedure, and 6 ports are used for robotic assisted procedures. These are the port placement. It can vary depending upon the surgeon's preference and site of specimen surgeon want to extract the specimen from. Usually we keep 2 10 mm, 3 5 mm ports. First and most important step in all the foregut surgeries, stable retraction of the liver. There are a couple of methods. Either we can use Nathanson or T-lift or this simple ethylene to a straight needle based for all our foregut procedures, be it esophagus, stomach, or Vipples. We use this technique and we are very comfortable with this. We pass a echelon 20 straight needle from the right of the falciform and then take it through the gauze piece and then from the left lobe parenchyma. And throughout the procedure, it gives such stable retraction that entire procedure can be done without any inconvenience. First step for radical gastrectomy is to enter in the laser set. Once we complete the diagnostic laparoscopy, this is very important area to evaluate because peritoneal metastasis can be there in the laser sac, and if you are doing robotic procedure and we dock the robo, then it will be a unnecessary expense to the patient as well as to the system. So always open the laser sac, confirm the operability, and then only proceed for the docking if you are doing robotic assisted surgery. And for laparoscopy, this is the step which completes our diagnostic laparoscopy. Once operability is confirmed, we start dissecting along the embryological plane, separate the mesogastrium from the mesocolon and the underlying pancreas. Usually, we get a very good plane of dissection in between. Once we define the correct plane of dissection, we have to simply follow the plane, and that plane will lead us to the subsequent steps. As you can see here, we are working on the entry surface of the pancreas. This is the entry surface of pancreas. My spatula is working in between the fourth layer of omentum and entry surface pancreas. That's a typical bursectomy plane. And once that plane is defined, we start separating entire of the mesocolon from the stomach. Aim here is to work along the inferior border of pancreas and define the gastropancreaticocholic trunk so that we can take the right gastroepiploic vein from the origin. In this pursuit, we might have to clear some of the station 14 V lymph node, which is not typically part of uh, D2 lymph node dissection, but many a times it actually helps us in defining the GCPT in very appropriate way from the origin, and so that we can take entire of the lymph node basin along with the specimen. As you can see here, we are seeing the trunk of Henle and the origin of GPCT. Here we are clipping the right gastroepiploic vein and cutting. Once this is divided, we can release the subsequent infrapyloric area from the mesocolon and skeletonize the duodenum. Here, as you can see, this is the colon and this is the head pancreas and duodenum. So gently we are trying to separate everything from the mesocolon. Care here shall be taken that neither we can injure the colon or the wall of duodenum. So we have to be very careful here as we are working along with the harmonic. We have to be wary of its active blood where it's working. And once that is done, we can focus on the right gastroepiploic artery, which is arising from the GDA. This is the right gastroepiploic artery. Once we skeletonize the vessel, we can clip it, and that's the end of station 6 lymph node dissection along with clipping of right gastroepiploic artery and vein. Once that is done, we can either lift the stomach, and from that plane only we can go towards the common hepatic artery basin, or we can come from the lesser curvature side. My preference most of the time is to follow this right gastroepiploic artery, and subsequently that will lead us to the GDA, as it is arising from the GDA, and from there we can trek towards the common hepatic artery. As we can see here, station 8A lymph node is automatically been lifted from the common hepatic artery, and we are nicely seeing the pulsation of the common hepatic artery. Care here has to be taken not to hold the lymph node. Whenever we are trying to hold the lymph node, it gets break. So either we keep the lymph node with the specimen, or if at all we need to hold, we have to hold the perinodal tissue and not the lymph node. Here we are trying to define the left gastric vein. Here we are define the left gastric vein, and we can now buzz it or clip it. Why we clip this small vessel is because this clips can actually guide us at the time of subsequent station 12 lymph node dissection. That is the reason we clip this vein so that it can act as a landmark in the later part of the dissection. Now we have already defined the left gastric artery. This is the left gastric artery. Usually we try and define the entire course of left gastric artery so that we don't miss on any of the left accessory hepatic artery. As you can see here, left accessory hepatic artery is arising from the left gastric artery. So if we see the left gastric artery and clip it, then sometimes accidentally we may hamper the blood supply of the left lobe of the liver. So it is very important to define the course, or better to evaluate it beforehand on the imaging, whether if at all there is anatomical anomalies there or not for hepatic artery. Once that is done, we have to be sure that we are clearing everything uh, from all around the left gastric, as well as from the other important. Here we are scrutinizing the splenic artery. This is splenic artery. We are trying to go along the splenic artery. This is station 11P lymph node, situated on the proximal part of the splenic artery. As we go along, everything is been lifted with the specimen. As you can see, we are working with the harmonic, and most efficient part of the harmonic is the tip of the harmonic. So better to grasp only half of the blade tissue with only half of the blade of harmonic, and work along the dissection plan, and subsequent plane will get opened very easily. So as a surgeon, we must understand how every single energy device work, and that will give us very fair idea of where which instrument has to be used, and accordingly we can select our instruments wisely. As I was saying, we have circumstantially cleared the left gastric artery, and then subsequently we can dissect the other part. Similarly, as I said, this basin can be approached from laser momentum by cutting the laser momentum. Uh, in previous video, what we saw was the lifting of the stomach and subsequently reaching that lymph node basin. Here we are actually retracting the stomach downward and reaching on the basin by cutting the laser momentum. Here we are working at the superior border of the pancreas. As you can see here, this is the pancreas. We are taking every single fibrofatty tissue with the specimen. This is the area where this is station 8A lymph node. By lifting this station 8A lymph node, we'll be able to see the common hepatic artery in the base. This is visualization of the common hepatic artery. Once common hepatic artery has been visualized, we can try separating it from the station 12. We usually, so my preference is to take station 12 separately and not with the station 8, as they are in continuity. But if you try and take everything en masse, that station 12 may get a break in between. So I prefer to separate station 8, then go towards the left gastric, define the left gastric, delineate it completely, go towards the splenic artery, again delineate everything, and take every fibrofatty tissue with the specimen. So here, as you can see, we are trying to skeleton all the major vessels, and keeping all the fibrofatty tissue with the lymph node bases with the specimen, so that integrity of the specimen as well as completeness of the lymph node, both will be achieved in one go only. It will save time as well as it will uh, maintain the field very dry. As you can see here with the combination of monopolar and the ligacure we are working here. Usually I try and keep the energy device in combination. So if I'm using like harmonic, then I'll keep the bipolar in other hand. If I'm using the monopolar, then I'll try and keep the ligacure as a standby as and when required. Here we are seeing a small hump of the leg, splenic artery. We have to be careful, otherwise we will hit the splenic artery. This is a small branch of the splenic artery, short gastric artery entering in the specimen, which we can burst with the ligacure now. We can also clip, if ligacure is not available, we can clip it also. Once everything is been cleared, we can clip the left gastric. Here we are trying to now define the station 5 and station 12A. We try and circumferentially clear the common hepatic artery. This is the common hepatic artery where it's meeting the GDA. Here we are clearing station 5 and hoping to see the right gastric artery. Once the right gastric artery is seen, we can either buzz or clip. My preference is to clip it so that we can have a very clear picture of where our vessels are. This white clips actually works as a landmark during the subsequent steps. So I always try and put some white clips. When right gastric artery is clipped, we can safely cut the duodenum so that we can approach the station 12 in much better way. This is at the end of dissection. Station 12 is still to be done. This is the time we start dissecting again. Marks right gastric artery, left gastric vein, and subsequently we will clear entire of this lymph node basin so that we can clear entire of the area on the left of the portal vein and the hepatic arteries. These are all lymphatics and fibrofatty tissue with the lymph node. With the suction, we are trying to retract the common hepatic artery. This is the clipped area of the left gastric vein, which is entering in the portal vein. We are working on the left of the left hepatic artery. And as we are working here, we are trying to stay away from the portal vein and take every single bit of tissue away from the portal and hepatic so that we can take it en masse completely. So this is the left of the portal vein. We'll go right up to the merger of portal vein with the caudate branch. We are seeing the caudate lobe and its branch. This is the end of station 12 lymph node dissection. When that is done, we can focus on the retrocurvature curvature. We can finish station 4D and subsequently station 2 lymph node dissection. This is splenic hilar dissection. Now, according to the recent edition of AJCC, station 10 lymph node dissection is no more part of standard D2 lymph node dissection. They are seldomly involved, so no aggressive lymph node dissection along the splenic hilum is required anymore. Here we are trying to define and cut the left gastroepiploic vessels. Once that is cut, our focus will be to cut the short gastric. So these are the short gastric vessels we are trying to cut from the splenic. And once that's done, we'll be complete with our dissection and specimen will be hang at the level of vitals, where we need to aggressively dissect all the station 1 lymph node, making sure we are not cutting the fibers of diaphragm until unless they are required. Once we reach here, we have to cut both the vagus now so that we can pull the esophagus. Here we need to be wary of the fact that we may injure the pleura, so that we have to be very careful when we are working in this area. Monopolar is the best way we can work in this particular field. We can also loop around the G junction so that we can pull the specimen downward with the umbilical tab, as I'm doing here. Once we have looped, our assistant can hold this and then we can safely work along the hiatus so that we can clear the esophagus for a couple of more centimeter for the safe anastomosis. I know that now literature does not support aggressive omentectomy in all the cases, but as a standard protocol, we are doing at our center omentectomy in all radical D2 gastrectomy for most of the gastric cancer patients. It's usually when we are doing robotic or laparoscopy, they are taken out as a separate specimen. For specimen extraction, we have to be wary of the fact that every single bit of tissue has to come in the glove bag or some form of specimen extraction bag so that we can avoid pot site metastasis. Then, according to the location of the tumor, we can prepare the extraction site and subsequent anastomosis, which will be covered by God sir. For all total gastrectomy patient, we usually do feeding jejunostomy. For subtotal gastrectomy, it is not required. My preference is to take out the specimen from the infra-umbilical fenestral incision, but we can definitely do it from supra-umbilical midline incision as well. Thank you very much.
Thank you, Dr. Devendra. It was an interesting video presentation. Actually, I have one very basic doubt. The
Please.
laparoscopy part which you had shown, what camera system were you using for it, sir?
So, as you can see, we were using robotic system only. So,
Yeah.
so many a times our procedures are hybrid. For Whipples and gastrectomy, we try and finish the resection part
Okay.
with laparoscopic instruments and then dock so that we can save on time and sometimes on instruments as well. So
Okay.
they are kind of hybrid procedures.
Okay. Okay.
So your assistant is going to have be holding a much heavier camera, isn't it?
True, sir. That is true, sir.
Anyway, yeah, great job. It was always good to see you show your videos, see you operate and show your videos. Truly, you are very inspirational. Wonderful job.
Thank you, sir. Thank you.
Thank you, sir. So you may end your screen sharing.
Sure.
I'll introduce our next speaker. He is Dr. Jagdishwar Gaur, consultant surgical oncologist and robotic GI gynec oncologist at Apollo Hospitals here in Hyderabad. He will be presenting a video tutorial on reconstructive techniques post total gastrectomy. Sir, Jagdishwar sir, over to you.
Yeah.
You may share your screen.
First, let me thank Subbu and all the IASO leadership for giving me this opportunity. Okay. Are you able to see now?
Yes, sir.
Yes, Jagdish, yes.
You can make it full screen, sir.
Is it full screen? No.
It looks vertically oriented. Okay.
Oh, no, that's okay. That
Okay,
will come.
okay,
That
sir.
will come. That will come.
Okay, okay, no problem, sir.
Okay. I thank all the ISO leadership for giving me this opportunity. This is a vertical because it's a phone app where we use, I think, before we do any radical surgery or anastomosis, the 3D anatomy orientation is very important, and anatomy is the root of success for all of us. And even now, we refresh our anatomy. There's so many apps online on iPad, and this is my iPhone, where we check the anatomy and then abnormalities like Devendra told, left gastric artery and all. And it also helps us in refreshing the structures where we are and how we are doing it. So every youngster must do it. Most of the time I do it, especially lung surgery or something like that. It's a very good app. So I have cut off the gastrectomy part. I start with the duodenal transection. I'll show gastric anastomosis as well as the GJ, JJ, and total gastrectomy as well as Iver-Lewis, because most of the time adenocarcinomas of the G junctions are increasing nowadays. I do total robotic. I don't use both lap and robo for technical purposes. And there are methods of doing either we do duodenal transection earlier or later. It doesn't matter. It's matter of technique. This is after the gastrectomy. I just included this because it's one of the basic anastomosis. A small incision is given. A stitch is placed to um, bring the small bowel. You can see the small bowel here and the stomach here, and then side to side incision is given and a stapler is inserted. Earlier days, the staple, it doesn't matter whether it is a Signia or the manual, but robotic definitely has an advantage. Once the side to side anastomosis is done, we can close the rent with the sutures, a small rent. This is magnified view. It's quite most of the people do that. And then distal to the anastomosis, we can use a transection to cut off the specimen side. Specimen side is still hanging there. As usual, follow the oncological principles, remove the whole of lesser curve and at least 5 centimeters away from the tumor on the greater curvature side. Oventectomy, the lymph nodes, as Devendra told, all the thing is done. And once anastomosis is done, distally, proximal to the anastomosis, we transect the specimen out and then remove it to a small pouch. Coming to the esophagogynostomy, after the total gastrectomy, this is the small G junction growth where it was more on the cardiac side. This is a total gastrectomy. This is the esophagus, and then this is the jejunum brought in. The side-to-side esophagogynostomy. A small rent is given in the jejunum side and the lower esophagus side. They're brought together after small incision. This is a robotic stapler, and then sure form stapler. Then we go in and do a side-to-side anastomosis. The whole specimen is hanging down. Our institute, though it's a contentious, we usually send for pronal section of the distal margin. So we have not yet resected it here. And then side-to-side anastomosis is done in that way. It takes a little bit of maneuverability. I found robotic stapler is quite good in maneuvering the anastomosis, especially in the Iver-Lewis and after total gastrectomy. Partial gastrectomy it doesn't give much advantage. And then distal to the anastomosis, we transect the specimen with in the lower 1/3 of the esophagus. Here, a bit of transrectal dissection is necessary before we do this anastomosis. The axis of the robotic stapler gives good, especially multiple staplers are needed. In such cases, robotic stapler is quite economical. In fact, recently a study came out from USA. The robotic staplers have increased more than manual staplers there. And the rent is sutured. As you all know, it's quite easy to do. I don't use a needle holder. I use the progress to suture to save some money, avoid one more use. And the jejunostomy, a small rent is done, and side-to-side jejunostomy with anastomosis is done. There's no point using a stapler here because it just requires a small rent there. Usually side-to-side anastomosis, then jejunostomy, and a feeding jejunostomy. This is just a stapler conduit creation before we do a for the lower 1/3 esophagus, the G junction tumors. That's the way the whole stomach needs to be mobilized and transatal. Here, a small attachment is given to the this is a lower 1/3 esophagus, and that's the esophagus gone inside. And then we go on to the intrathoracic side. We cut off the conduit there. Here we can use whichever stapler, and then anastomosis is done in the side-to-side staplers, robotic or manual, and then the rent is closed. This was the lower 1/3 esophagus. For the thoracic part, again I use prone. It doesn't matter, semi-prone, prone. It doesn't matter. This is another case of G junction. It was a very small. Very rarely we see this type of tumors. It was a 1 centimeter or 7 millimeters tumor, adenocarcinoma. Our tumor board, the patient was given an option and he chose surgery. Even the tumor board called him and then gave a decision. This is the hiatus mobilization. This is the stomach side, and that's the esophagus side. And tumor was not at all. There was no bulk of the tumor. So What we did is prior endoscopy, we marked it with ICG on the same day. And then the dissection without ICG. The protocol we followed, same protocol, removing the lesser omentum right from the this thing and the lesser curve and create a conduit. And now you can see the tumor was not at all visible. And when we used ICG, we could see the site where it was. And we went distal and proximal to that and sent the frozen section. Luckily, there was a focus of adenocarcinoma there, and margins were clear. So this was one of the difficult cases where tumor is not seen and we had to operate. It's very quite rare. Patient actually went for a chest pain and he was investigated thoroughly. He came from US on this. Then transitally we mobilize a little bit. A good mobilization is always necessary before we do any anastomosis. All people know. Then the dissection is done. Peri-adventitial area, clear out lymphatics and negative, but still we cleared the lymph nodes along the lesser curve and posterior side there. And then if you see here now, when ICG is not there, it looks very clean, but when ICG is there, we could make out the disease. And then we went inside. Once we mobilized it, we pushed the specimen into the esophagus. That's how we do the transital dissection. And then this is intrathoracic. If you can see the tumor here, 2 centimeters above, up to near till the azygos vein, we mobilize it, and then cut the under ICG guidance, cut the disease above and below. Then this case, we did the hands-on anastomosis. And the edges are quite oozing. We don't cauterize because we're scared of vascularity, even without ICG, good circulation. And then above, this is above the tumor, we let the edges ooze. We didn't want to burn the tissue there. And then even below, it is cut. And that's the anastomosis. This was an end-to-end anastomosis, 2-layer. We used relock sutures. This is a prone position. This is a lung, and this is a hiatus, and this is the end-to-end anastomosis. So these are the different anastomosis we are using, but of late we are finding more cases of Iver Lewis with G junction. Most of them are post-chemo, but we do get early cases. Sometimes we do single layer. Most of the time we do single layer, but sometimes we good lie is there, good fall is there. We do 2-layer. I think single layer is quite accepted. So these are the different anastomosis we do over the gastrectomy and put the specimen in a small pouch and take it out through a small incision. And we do pharyngectomy for most of the cases initially. That's about it. I think I'll stop my share. I hope the video was visible.
Yes, sir, the video was visible. There was some
I think I
lag,
was
but
given,
I think it was.
12 minutes or something like that, so I didn't want to drag.
No, sir, you were well in time.
And it's very crisp, very clear. No problem. Wonderful.
Right, sir. So I think we can. There is one question for you in the Q&A section, sir. Can you mention the name of the app and the details to use it?
They're asking you about the app more than your your robotic work. But Jagdish is a pioneer in robotics across the country, a mentor for practically
It's
most
a
of the
visible body.
places.
It's a visible body app.
What is it called?
It's human body, no?
Yeah,
The
visible.
iPad or iPhone app.
Yeah, I bought it for. I don't know. I mean, your background is.
Oh yeah, it is. So the app is called Human Anatomy
Yeah,
or Human Body.
you can have a virtual reality also. No, you can
Yeah.
rotate it.
Yeah, various
You can
organ
do.
systems have
Yeah,
3D reconstructive. You can reconstruct for the
yeah, yeah,
vasculature and everything. It's a
yeah,
very
yeah. You
handy
can do
app.
that. You
Even I
can,
use it.
yeah, yeah, yeah. It's a very good app. I use it almost for 5 6 years.
Yes, sir. Yes. Thank you so much, sir. We can bring this session to a close. I invite Dr. Rudra, sir, to kindly give the vote of thanks. Rudra, sir, are you there online?
Yeah, I think both the presentations were super from Devender and Jagdish. I think the lymph node dissection were quite clear, very well explained to the all stations. And Jagdish is master in robotic anastomosis. Give anything, he will join together. So I think he did a lot of varieties and innovations. And I didn't know about this app also. I will try to use from now onwards. I think, and I thank also the Indo-American team for arranging the whole thing. And I think today see you or some on the Zoom platform, maybe more on YouTube and other. Subbu sir, thank you very much for guiding us. Thank you very much.
Thank you, sir.
Thanks a lot.
Thank you. Yeah. So we bring this session to an end. So the next session, as I have displayed, will be on gallbladder cancer. We will start with the masterclass and followed by mastery on the same gallbladder cancer. Thank you all for joining us. Have a good evening.